Now move on to the next session. I would like to invite Chairperson Dr. Ajith Kumar S, Consultant SP Fort Hospital, Professor of Medicine SUT Medical College Hospital, to the dais.
Good afternoon, ladies and gentlemen. I think we'll continue with the academic sessions. The next talk is basically about a topic that is understanding GLP-1 therapy in non-responders, uncovering a hidden barrier in obesity treatment. We have speaker Dr. Krishnadev Jothydev. He is currently a resident in MD Medicine at Sri Gokula Medical College. He is the best orator 10th TESA Diabetology in 2024. And he is an author in multiple articles and original publications. He won the first prize in paper presentation in Medifest National Medical Conclave happened, and he is a presenter in National Conference on Students Medical Research in 2019. He is a young speaker. I welcome Dr. Krishnadev Jothydev to deliver his talk. Over to you, Krishna.
Thank you, sir. Thank you for the kind words of introduction. A very good afternoon, one and all. First of all, I'd like to thank my father, Dr. Krishnadev, and the organizing committee for giving me this wonderful opportunity to speak on a seldom discussed area, with understanding the GLP-1 therapy in non-responders. So we've been discussing about the success rates of GLP, and of course, the GLP-1 family are blockbuster molecules, but despite all the evidences, a significant proportion of subjects are non-responders in terms of body weight reduction and HbA1c reduction. So this is a clinical puzzle, and this is my humble attempt to explore the reasons why there are non-responders. So before going to the topic proper, let me just define some of the categories. So we have responders. Responders are those who achieve 5 to 15% of total body weight loss. And we have super responders who achieve more than 15% of total body weight loss with GLP-1 therapy. And we have non-responders, our area of concern, who achieve only less than 5% of total body weight loss, not achieving the acceptable more than 5% cutoff. And we have slow responders, an upcoming term, subjects who achieve less than 5% in the initial weeks, and then later on, after the end of few weeks, they achieve more than 5% weight loss. So these are the list of GLP-1 families available. So we had exenatide way back, and now we have the injectable Sama. We witnessed the launch of Wegovy yesterday. So understanding the list of these molecules will help us guide further. So before I jump into the reasons for response, let me just guide you briefly through the mechanism of action of GLP-1 So when there is food intake, the GLP-1 is secreted in the gut, and then it acts in the nucleus tractus artery and the area prostoma in the hindbrain, and then later on projects to the hypothalamus in the arcuate nucleus, whereby it increases the anorexigenic signaling of pro-opiomelanocortin and suppresses the orexigenic pathways of the neuropeptide Y and agotylated peptide. It also acts at the reward centers in the brain, where it mediates the dopamine release. And ultimately, it suppresses the appetite, delays the gastric emptying, and reduces the food intake. It also acts in the periphery, whereby it enhances the insulin secretion and suppresses the glucagon production. Now let us compare the major clinical trials with regards to GLP-1. The STEP trials and the SURMOUNT trials. The STEP trials, they looked at injection semaglutide, and the SURMOUNT, they looked at tirzepatide. The STEP 1 had a population of obese or overweight individuals with no diabetes. And STEP 2 had individuals with obesity or overweight with type 2 diabetes. The STEP teen had individuals who were adolescent and had obesity. The SURMOUNT 1 had obese or overweight individuals with no diabetes. And the SURMOUNT 2 had individuals with diabetes. So if you look at closely, on the far right, you can see the percentage of non-responders. Every single trial had a significant number of non-responders. And if you look more closely, you can see in the STEP 2 and the SURMOUNT 2 trials, where subjects had diabetes, the percentage of non-responders were more compared to the other population. And even the mean weight loss was lower when compared to the other trials. So this signifies that subjects having type 2 diabetes have invariably a reduced response to GLP-1. Now let us examine why this happens. It may be because of the blunted incretin effect that you commonly see in diabetes, and 30 to 50% of incretin response is lost. There is increased insulin resistance, and these subjects may already be on other weight gain promoting medications like insulins or sulfonylureas, which may mask the effects of GLP-1 and there is altered gut-brain axis, especially in diabetic autonomic neuropathy, where the gastric emptying is hampered. And the long disease duration invariably signifies beta cell exhaustion, which again implies that GLP-1 RAs are difficult to work upon. Now let us examine the other clinical reasons for non-response to weight loss. It can be because of the inadequate dose or duration, not reaching the target dose of 2.4 or 15 milligrams, a poor adherence, missed doses or wrong ingestion practices, and a compensatory behavior of increasing the caloric intake or decreasing the physical activity for energy conservation. And then you have genetic variation in the GLP-1 receptors. It can be central or peripheral pathways, and these subjects may already be on other weight gain promoting medications like antipsychotics or steroids. And the underlying health conditions like hypothyroidism, PCOS, sleep apnea can also affect the GLP-1 response. Now this is a recent work from Avadhesh Kumar Singh et al. He looked at the predictors of non-responders versus responders to tirzepatide, a dual agonist. I'll be sharing a few insights from this study. So it is shown that there is emerging evidence that women respond differently to GLP-1 RAs and tirzepatide. Why? Because the female gender has a more pronounced effect, probably because of the higher estrogen levels, especially in premenopausal women, which improves the insulin sensitivity to GLP-1 RAs and stimulates the pancreatic GLP-1 secretion. And moreover, this elevated estrogen enhances the brain's responsiveness, the hypothalamic responsiveness to GLP-1 signaling. And also, there are sex-specific differences documented in the specific neural pathways involved in GLP signaling. And all these may contribute to the difference of gender. Moreover, that being said, women also experience higher rates of side effects with GLP-1 RAs and also more drug withdrawals. So, this can be because of the lower average body mass in women, resulting in higher drug concentrations for a given dose. So this amplifies the therapeutic effects in one hand, and on the other hand, it increases the drug effects. So these are the clinical and the demographic predictors for HbA1c and weight response. Over your left, you can see the dark green arrow, and these are the factors that exaggerate the response to GLP-1 RAs. It can be a higher baseline BMI, a higher baseline HbA1c, a short duration of diabetes, drugs that already delay gastric emptying like mosapride, the female gender, hyperestrogenemia that I've discussed before, and also a preserved beta cell function. And over your right, you may find the factors that blunt or suppress GLP-1 response. The presence of autoantibodies in type 1 diabetes, lower fasting C-peptide, lower BMI, a beta cell dysfunction, and a long duration of diabetes. This is another graph that explains the genes that are involved in GLP-1 response. Now you may find the top arcs over there. The purple arc is HbA1c and the orange arc is body weight. And the top arcs are super responders and the bottom arcs are non-responders. So you can find the genes like the WFS1, the Wolfram syndrome 1 gene, a very famous gene, and its SNP variant is common to both HbA1c and body weight. It both exaggerates the effect on HbA1c and body weight. And you have a long list of other genes on the bottom, the non-responders like the GLP-1 receptor RNs mutation, the JPEF, the free fatty acid receptors, the voltage gated channel receptors, and all these, they decrease the response to GLP-1 RAs. Let us break this down further and examine the mechanism behind these genes. So you have the GLP-1 receptor over there. Its SNP variant, the RS69237161, it has a blunted effect on HbA1c, whereas an exaggerated effect on body weight reduction. And this is because of its mechanism on delaying the gastric emptying. And you have the other variant, which has the blunted effect on both HbA1c and body weight. And you have the potassium channel, the KCNQ1 gene, and its SNP variant, which has a blunted effect on HbA1c, especially in the E stations, implying the ethnicity also plays a role here. And you have the very famous Wolfram syndrome 1 gene that I discussed before. It has its mechanism by relieving the stress of the endoplasmic reticulum and thereby exaggerating the reductions of HbA1c and body weight. And we have a long list of other genes. It can be quite overwhelming, but each have different mechanisms of action by which they have its effect on HbA1c and body weight. Now that we've discussed the effect of GLP-1 RAs in subjects with type 2 diabetes, do we have any data on subjects with type 1 diabetes? Yes, we have. And this is another recent work from Viral Shah and team from the USA. And they looked at the effectiveness of GLP-1 RA therapy in people with type 1 diabetes and compared it against subjects who had a genetic form of obesity versus subjects who had obesity which is unlikely related to a mutation. So what they found was that individuals who had genetic obesity achieved fewer weight loss goals. Fewer individuals achieved the weight loss goal of more than 5% or the HbA1c reduction of more than 4%. Meaning genetics also play a significant role, and of course we need further research to prove upon this. Now that we've discussed the clinical, the hormonal and the genetic factors with regards to GLP-1 response, let us look at factors that are associated with the receptor level biology. Of course, the GLP-1 and the GIPR act via the class B protein coupled receptors and they signal via the G protein coupling, and some molecules like tirzepatide, they are co-agonists and they are also biased agonists. They act by increasing G protein signaling and also recruit less beta-arrestin, which is a key regulator of the GLP signaling. And by doing so, there is more increased receptor recycling and also improved insulin secretion. And we have genetic variants as well, the loss of function variants and gain of function variants. And the gain of function variants are associated with improved G protein signaling and enhanced insulin secretion. In order for the GLP-1 RAs to work, a cholesterol-rich, a lipid-rich microenvironment is essential. And disruption of this with the help of some fatty acids or with the use of statins can influence the GLP-1 RA response. And these receptors, once activated, they may reach the receptors or they may be trafficked to lysosomes. And these trafficking can also affect the GLP-1 response. And of course, the previous speaker spoke much about the microbiome signaling. There is a lot of data on this. The short-chain fatty acids affect the microbiomes and it improves the production of free fatty acid receptors from the microbiomes affect the GLP-1 response. The beneficial bacteria like the bacteroids can improve the response to GLP-1 RAs, whereas bacteria like Myxocola, which are non-beneficial bacteria, may increase the non-responders to GLP-1 RAs. And the GLP-1 RAs, they cross-react. They interact with other heterodimers and they form different receptors, and this may also affect the signaling process. And these stimulation of free fatty acid receptors can blunt or they can improve the response to GLP-1 RAs. So co-expression is also another important factor. So these are my key takeaways. So many of these findings are just hypothetical and this is an area to work upon. Of course, non-response to GLP-1 RA is clinically relevant, it is not rare, and it is an area of concern. Around 10 to 30% of individuals are not responders in all the major clinical trials. And of course, genetic variability is the reason. And type 2 diabetes itself may be a predictor of non-response, and the female gender has shown to have better response rates. And the future is integrating pharmacogenomics, microbiome profiling, and also receptor biology level to guide personalized treatment decisions. With this, I conclude. Thank you. I wish your patience.
Thank you, Dr. Krishnadev Jothydev. I think he has beautifully narrated the theory behind the non-responders. We can see that whatever we say, whatever we, genetics plays a major role. And one key point he was highlighting was even the diabetes patients, obese diabetic patients was showing non-responder category in the study. He had highlighted 2 studies. The topic is open for discussion. Any questions we can ask? You said usually ladies it is because of the estrogen.
Yes,
sir. Is it has got any specific role this estrogen plays in the mechanism of GLP-1?
The hyperestrogenemia is as such shown to improve the response. The response is related to the molecular biology level. It's quite complex, but there is emerging evidence that the hyperestrogenemia can play a significant role in GLP-1 response. So we need more research. We are in dearth of data, but in the future we might land in a conclusion.
Any other questions from the crowd? Okay, let's stop there. Please give me a big round of applause. Thank you.